The upper extremities are frequent sites of painful musculoskeletal syndromes, especially in occupational health settings. Many patient visits involve the shoulder, wrist, or hand, and understanding these common disorders is important for both recognition and management. Bursitis and tendonitis are among the most frequent conditions. Bursae are fluid-filled sacs that help reduce friction during joint activity, but when inflamed, they become painful, resulting in bursitis. Tendonitis occurs when tendon sheaths become inflamed, often due to repetitive stretching. The inflammation restricts joint movement, leading to pain and weakness. Conservative treatment typically includes rest of the extremity, intermittent ice or heat, and non-steroidal anti-inflammatory medications. Newer therapies like shockwave treatment, pulsed magnetic fields, laser phototherapy, and stem cell therapies are being explored, but evidence for their effectiveness remains limited. Corticosteroid injections are more evidence-based for short-term relief, although they are not always helpful long-term. Most cases of bursitis and tendonitis resolve on their own, with treatment primarily aimed at pain relief rather than cure. Another issue that can affect joints is the presence of loose bodies, sometimes called joint mice. These fragments of cartilage or bone result from joint wear or erosion. They can interfere with movement by locking the joint. Arthroscopic surgery is often performed to remove loose bodies if they cause significant pain or mobility problems. Impingement syndrome refers to impaired movement of the rotator cuff in the shoulder. It commonly results from repetitive overhead arm movement or acute trauma, which irritates the rotator cuff tendons or the subacromial bursa. Early signs include shoulder pain, tenderness, limited movement, and muscle spasm. Over time, it can progress to a partial or complete rotator cuff tear. Treatment for early impingement often begins with non-steroidal anti-inflammatory drugs or corticosteroid injections. Superficial cold or heat may improve symptoms, but long-term improvement requires a therapeutic exercise program focused on strengthening and restoring shoulder function. Carpal tunnel syndrome is one of the most well-known upper extremity disorders. It is an entrapment neuropathy that occurs when the median nerve is compressed at the wrist. The condition is most common in women between the ages of 30 and 60, especially those going through menopause or using estrogen or birth control pills. Other risk factors include rheumatoid arthritis, diabetes, acromegaly, hyperthyroidism, trauma, and occupations that involve repetitive hand movements or exposure to vibration. Symptoms include pain, numbness, tingling, and weakness along the median nerve distribution, which affects the thumb, index finger, and middle finger. Patients often report night pain or fist clenching upon waking. A positive Tinel sign, tingling when the median nerve is lightly tapped, supports the diagnosis. Treatment may involve oral or injected corticosteroids, non-steroidal anti-inflammatory drugs, and sometimes acupuncture with electrical stimulation. Splints can help by preventing hyperextension and prolonged flexion of the wrist. Other treatments such as laser therapy, ultrasound, prolotherapy injections, and vitamin B6 have not proven effective. Long-term corticosteroid use carries risks of tendon rupture and is not recommended. If non-surgical treatments fail, surgery is often indicated. Open nerve release and endoscopic laser procedures are the two most common approaches. Both involve cutting the carpal ligament to widen the tunnel, though endoscopic methods result in smaller incisions, less scarring, and shorter recovery. After surgery, patients wear a splint, limit hand use, and may need assistance with personal care until function improves. Recovery of motor and sensory function can take weeks to months. Another condition is a ganglion, which is a cystic swelling filled with gelatinous material near tendons or joints, often on the dorsum of the wrist. These occur most frequently in women under 50. The swelling may cause aching pain or weakness of a finger if a tendon sheath is involved. Treatment options include aspiration, corticosteroid injection, or surgical excision. However, recurrence is common. Dupuytren disease is a progressive contracture of the palmar fascia that pulls the fourth, fifth, and sometimes middle finger into flexion. It occurs most frequently in men of Scandinavian or Celtic ancestry over the age of 50 and is linked to an autosomal dominant trait. It is also associated with arthritis, diabetes, gout, smoking, and alcohol use. The disease begins as a nodule in the palm and may progress to significant contracture with palmar skin changes. Patients may experience morning stiffness, numbness, and aching discomfort. Both hands are often eventually affected. In early stages, finger stretching exercises or injections of corticosteroids or collagenase may slow progression. If contracture becomes severe, surgical procedures such as palmar or digital fasciotomy may be required to restore function. When patients undergo surgery of the hand or wrist, the nurse plays a critical role in post-operative care. These surgeries are usually outpatient unless they involve major trauma. Before surgery, the nurse assesses the patient's pain and functional limitations. After surgery, neurovascular assessment of the fingers is performed hourly for the first 24 hours to monitor for deficits, especially if a tourniquet was used. Fingers are compared to the unaffected extremity, and the patient is asked to describe sensations and demonstrate movement. Dressings should support the joint without constricting circulation, and ice may be applied intermittently for 24 to 48 hours to reduce swelling. Patients are taught to elevate the hand to heart level to control swelling. Oral analgesics are prescribed to manage pain, and patients are educated about the risks of impaired mobility, infection, and compartment syndrome. Independence and activities of daily living may be impaired for several days, requiring assistance with bathing, dressing, or feeding. Patients are encouraged to use the involved hand within the limits of pain and surgical restrictions, and rehabilitation exercises guided by therapy may be prescribed. Home and community care focus on teaching patients to monitor for complications such as excessive swelling, bleeding, signs of infection, or changes in sensation. They are educated on proper wound care, safe use of assistive devices, and strategies for adapting self-care while recovering. Supportive measures such as keeping dressings dry during bathing, using splints, and applying ice when prescribed are reinforced. Nurses also help patients identify barriers to successful recovery and connect them to community resources as needed. In summary, upper extremity disorders are common and often linked to repetitive movements, occupational exposures, and inherited conditions. They may range from self-limiting inflammatory issues like bursitis to progressive and disabling conditions like Dupuytren disease. Management strategies vary from conservative therapies and medications to surgical procedures, with nursing care focused on symptom control, functional recovery, and patient education.